to improving the services that we provide in Soweto. That would be renovating the entire facility. We've recently just opened up our new labour ward, and we've been doing so over the past few years. So we're still seeking to ensure that we create the best kind of facilities for our people within the communities. You know, these facilities were built by the community, for the community, so we'll continuously help to grow and improve.
So we've recently opened our new labour ward, which is now bigger and better, state-of-the-art equipment. The new things that we've included there is the water bath. You know, for women who'd like, you know, water is used also as a form of pain management in labor. So if a woman has a preference, this is a new thing that has been put in our ward, then the woman is given that option to deliver there. We've got new beds that are state-of-the-art when the doctors are delivering their patients without any difficulties. In our new maternity ward, we've included a new nursery, which is much bigger, which has more better equipment, cardiac monitoring of the baby, so that we don't miss any abnormalities on the new baby, because anything can happen. Baby can come, you think the baby is well, can't you? If you don't have the proper cardiac monitors to monitor these babies, you can miss something. And also, you know, we've got neonatologists who works hand in hand with us to manage these precious babies. So those are the things that we've included, and they are working perfectly.
Oh, thank you, Kamo. That went so quickly. I'm still enjoying watching the video clip this evening and looking at people still entering the church room. There's still quite a number of people coming in. So we just want to welcome everyone who's joining us this evening. Once more to our weekly webinars, Clinics Health Group weekly webinars that we started engaging with the medical fraternity, all colleagues, healthcare providers from different fields, both the public and the private sector, during the pandemic or at the beginning of the lockdown, the hard lockdown. And so it has been a wonderful journey sharing these moments with you and getting experts from different fields sharing their knowledge, experience, and passion about what they do at the workplace and in academia and also in the clinical settings. And so this evening is one of those proud moments that we have of sharing this time with you once more. And we just want to thank you for being faithful supporters of this program for Clinics Health Group, that you've stayed with us all these last 2 years. And it's because of you that we are able to continue to bring your accomplished speakers, clinicians in their own fields to come and share their knowledge with us here at Clinics. And as usual, we just want to encourage you to also indicate if you also want to be participating in this platform as speakers to share your knowledge. Know that there are quite a number of colleagues who are on this platform who are experts in their own fields also in various situations where they are placed. So do please send us your information and the topic that you want to share with us. The email address to use, come all write it down. It's webinars@clinics.co.za, or you can send me also a message via email. We'll post my cell phone number too that you can also use. It's my email is rbilla, RBILLA@clinics.co.za. And Gamo, you'll put down my email address and also my cell phone number. So if there are any colleagues who want to contact us and indicate the availability to share their knowledge or refer us to other experts in the field who are able to share with us on this platform. And so do know that these webinars are CPD accredited, and we also stream these webinars live on YouTube, so that at the end of the presentation the following day you can access these presentations on YouTube to watch at your leisure time and to go over items or slides that you may have missed or you want to get more detailed information about, so you are able to do so at your leisure. Plus, also do like us on YouTube, so that we know that you're watching these pages on YouTube, and also spread the information to your colleagues, your friends, family members, so that they are also aware of what we do at clinics and what kind of information that we share on this platform. These meetings are also CPD accredited. So if you're registered with either the HPCSA or the Pharmacy Council or the Medicine Council or the Allied Health Professionals Council, you may add your information, details, registration number, so that you can share with these regulatory bodies and you can get CPD points where it is relevant. And if you're not a member of the health profession, you don't have to, you can just give us your ID number or any other information that you can use for us to capture your details and share information. If you do not get reminders about these webinars, please also do indicate, send us a message to webinars@clinics.co.za so that we can add you onto our database, because I've noticed that some colleagues have indicated that they may not be getting invitations. So please make us aware so that we can add you onto our database. So this evening, I'm quite excited to bring you another established speaker, Dr. Jacqui Brown, who's a specialist intensivist and also Deputy Director of Chris Hani Bara Academic Hospital's Intensive Care Unit. Dr. Jacqui, prior to this, she was the Principal Medical Officer in ICU. She boasts over 30 years of experience working at Chris Hani Bara Academic Hospital, one of the few. Some of the people I've met when I was still at Bara, quite a likable experience I've enjoyed with them. She completed a Bachelor of Medicine in Bachelor of Surgery, MSHB in 1986 at Wits University. In 1989, she completed a Diploma in Anesthetics at the College of Anesthesia, South Africa. She further completed a fellowship at the same College of Anesthetists of South Africa, focusing on critical care in 1999. She has participated in numerous clinical trials as both principal and sub-investigator. She has also peer-reviewed over 7 publications relating to critical care. She is an examiner of the Certificate of the Critical Care for the Colleges of Medicine of South Africa, and she is the chairperson of the Pharmacy and Therapeutics Committee at Chris Hani Bara, and also a member of the Gauteng Provincial Pharmacy and Therapeutics Committee, quite an important committee that she heads there to manage our essential drug list and medicines that we issue to our patients in the public sector, and I think also in the private sector. So this evening, Dr. Jacqui Brown has agreed to talk to us on a very important topic about are we talking to our patients and surrogates. And it's a pleasure to welcome you, Dr. Jacqui Brown, to address us on this important topic, so we learn how to speak to our patients and surrogates. Thanks, Jacqui.
Thank you, Dr. Bila. Yes, and yes, we go back a way. I remember when you were still working at Bara. Yes, you're giving away our ages here. Okay, and tonight I'm going to, well, first of all, let me welcome everybody. Welcome to this meeting. Hope everyone is comfortable and warm. Sit back, relax. This is not the most taxing topic, but it is, I feel, very important. It's something that I feel very strongly about. So let's get right. Can everyone see? Are we okay?
Yeah, we can see. Sure.
Okay, great. Okay, so are we talking to our patients and surrogates enough? As I said, it's something that is quite close to my heart. And just a little bit of background. I became interested in this when my husband was admitted to hospital into intensive care. And just so you know, disclaimer, I my husband actually helped me with this talk and gave his insight into this talk as well. It is partly an ethical talk as well. And again, as a disclaimer, I don't profess to know everything about the ethics. And also just to remember that we have principles in ethics, but everyone's own perceptions are important. So a lot of your ethical principles and your moral standings depend very much on your religion, how you were brought up. So the answer to the question basically is a no. We don't talk to our patients, and that's what actually prompted this whole talk, the discussion thereof. Okay. First of all, I'm going to just start a little bit to just talk about a bit of background in ethics, and how ethical are we when it comes to talking to patients and surrogates. So I'm going to go through some of the principles, just to remind people of the principles of ethics and the guidelines. And we can just go through that, and then we can just apply some of these ethical principles to talking to patients and to surrogates. Right, we all know the basic 4 principles of medical ethics. There's autonomy, benevolence, non-malevolence, and justice. Briefly, autonomy is the rights of the patient. Beneficence is that the patient benefits from treatment. Non-malevolence is do no harm, and justice basically is that there's justice for all, so everyone is included. These are the basic principles that everyone talks about. But if you go, oops, sorry about that. But if you look at the Health Professions Council of South Africa and the guidelines for good practice and ethics, they actually have a much longer list. And the Health Professions Council of South Africa has 4 ethical values. And right on top of that is respect for persons. And that basically sums up most of your ethical values and core ethical principles that we have. So if you respect people, you should manage to cover most of your ethical principles. Again, non-malevolence, don't do any harm to patients. Benevolence, try and do what is in the best interest of the patient and will the patient benefit. Autonomy we've done, and justice. Then the other things, some of the other core values, so the Health Professions Council mentioned, is human rights. And this is very important. And this has come about from our constitution. And we've got one of the best constitutions when it comes to human rights in the world. And if you look at it, all your ethical principles are based on human rights and respect for human beings and the dignity and autonomy of human beings. So human rights is a major factor enshrined in our core ethical values. Then you have integrity and truthfulness. You need to be truthful and honest to patients. They need to know the truth, and you can't hide that. Confidentiality, I'm going to go into a bit more detail because it relates to the topic that we're talking about and talking to patients and to families. Compassion and tolerance. Compassion is something that every doctor and every healthcare professional should have. That's part of why you did medicine in the first place and why you went into healthcare, to have compassion for your patients. And then professional competency and community. So if you look at that, you can see there's a lot of morals and ethics involved in this. So you just have to respect for people is probably the most fundamental of all of it, and will cover everything. But I'm just going to have a few definitions if we're going to be talking about patients and surrogates, and are we talking to patients? So what is a patient? Okay. Basically, the patient is the person that is receiving the medical treatment. So this is the patient, the person that is sitting in front of you or lying in front of you in the bed, as the case may be, who has actually come to you to ask for help and ask for medical treatment. So that's your patient. Okay, your patient is not the relative. It's the person sitting in front of you asking you for help. So who's a surrogate? Okay, there are times when a person isn't able to make decisions for themselves. And that we see that often in ICU, where the patient is incapacitated and unable to make decisions. So this patient here has a surrogate. So the surrogate is a person designated to act on behalf of the patient. So especially if the patient is unable to act independently or is incapacitated. And that's an important concept. So surrogate is designated to act on behalf of the patient. And that's the important concept here. And then we all know the concerned relative. Okay. The concerned relative is not necessarily the surrogate. It's a very different concept. And we all have to deal with concerned relatives. And this is where confidentiality comes in. You're going to have concerned relatives. Okay, I'm going to just stop a minute. And I just want you all just to have I just want to ask you a question, and now you need to just think about it. Who of you have been patients? Okay, I'm sure there's quite a few. There's over 100 participants in this webinar. I'm pretty sure that within this group, you have been a patient, or someone has been a patient. And then the next question is, who of you have had a relative who's been a patient? And especially a patient who's been in ICU, who's been very sick, and you've had to be a surrogate for. I personally think that every single healthcare professional should become a patient at some stage, or at the very least, be a relative of a patient, because it's very different on the other side. And that's something I experienced when my husband was admitted. And I'm going to refer to this quite often because, as I said, my husband actually helped with this talk, and his insights helped me a lot. It's very different being on the other side of the table, on the other side of the bed. Just remember that. And just think about it. If you've been there, you'll know exactly what I'm talking about. Okay, so don't dismiss the concerned relative, because there's reason that they're concerned. They care. And you need to remember that. So let's go back to surrogates. Who are surrogates? If you have a patient in ICU, that patient, or any patient that's incapacitated, who is unable to make their wishes known, you need to have a surrogate who can make that decision. Now, the important thing to remember is that these surrogates make decisions, give consent, but they need to be aware the surrogate is there to represent the patient and to say what the patient would wish for. It's very important to know that surrogates cannot say what they want. They need to be able to say what the patient wants. It's not always so easy. Again, it's not always so easy to discern whether the surrogate is actually doing what they want or what they think their relative wants. So that's something that you need to think about. Now, a patient can nominate and should nominate a surrogate. And it's something that I think all of us should go and do. Who would you want to represent you when you're ill and sick and you can't make your own decision? Who knows you? Who is aware of what your wishes are? Okay, it's often your spouse or someone very close to you, a close relative. Go out there, discuss with who you want as your surrogate, and tell them what you would want if you were in a situation that you can't make up your own mind. It's something that you need to do. And it's something I think we need to encourage our patients to do as well. Okay, not all our patients obviously are in ICU with a tube down their throat where they can't speak, but all of us have patients that we can talk to. And I think we must start making people aware that there may be times when they can't make their own decisions. So speak to your patients, ask them to nominate a surrogate. It's even better if you have it in writing. It makes it so much better. So the patient can tell you who you want. So they may not want their spouse. They may want their brother or sister or someone. So they can actually nominate. If the patient hasn't nominated a surrogate, who else can you have? Obviously, a person authorized by the court can do it. But then your relatives are most commonly a surrogate is your relative. So in order of importance, the spouse comes first. Now, interesting, in South African society and South African law, your life partner, if you're not married, and if it's a common law husband or wife, actually comes next. That's the spouse, then the partner, then there's a parent or grandparent, depending on whether you have those relatives. If you're elderly, a major child, or eventually a sibling. So all of these can become surrogates. And as you can see, though, these are generally the people that would know you best and would know the patient best. And only in an emergency would the physician be a surrogate. Okay, I just want to now just a little bit on confidentiality. I've said right at the beginning that generally as healthcare providers, we are terrible at talking to patients. I'm not saying everyone, but in general, we tend to try and avoid talking to patients. I've just had one of my colleagues who should be on this talk. He's just had his mother admitted to an ICU, and he was horrified at how badly the doctors communicated, not just to him as a fellow doctor, but to his mother. They didn't even speak to his mother, some of them. They came in, had a look at the charts and disappeared without actually looking at the patient and talking to the patient. So we actually are very bad. I don't know why. It's something that we're not taught. And it's something that you have to actually become confident in doing. So you do need to talk to your patients. It's very important. But let's just go to confidentiality for now. One of the important concepts that is enshrined in our Constitution is confidentiality. And this relates to your autonomy in your ethical principles. And here you're respecting your patient's rights. And confidentiality is central to trust within the doctor-patient relationship. A patient has to be able to trust his doctor. If the patient feels that they can't confide in their doctor, they're not going to tell them everything. And then the doctor is not going to be able to put everything together and treat the patient appropriately. So it is very important to gain the trust of your patient. And one of these is that you must ensure that you have confidentiality. So generally, you must get the patient's consent to disclose whenever possible. So if you want to talk to someone else about a particular patient, you must get the patient's consent. If he is incapacitated or not able to give consent, then you can ask the surrogate. In what situations would you have that where you would need to break confidentiality or disclose things? Okay, the one obvious one is with fellow healthcare providers. We're very bad at confidentiality. Okay, we discuss other patients with other healthcare providers. So we need to be very careful of that. And it's especially bad in the academic hospitals where you have interns, you have medical officers, registrars, and fellow consultants. And in an ICU like ours, where we have medical officers and different consultants and sisters, everyone in the ICU, all the healthcare providers know every single patient, and they know all the details about all those patients. So we are bad at confidentiality. The National Health Act in 2003 makes it an offence to disclose patients' information without the patient's consent, except in certain circumstances. Now you can ask, what circumstances are there? Apart from children and people with mental incapacity, they're very vague, the National Health Act, and so is your Health Professions Council. They don't really define what certain circumstances are. Basically, Section 15 and 16 of the Act says you can disclose for any legitimate purpose within the ordinary course and scope of your duties, where such access or disclosure is in the interest of the user, i.e. the patient. So it's a little bit vague. So I think you need to just think about when you disclose things. So disclosure to a third party, I just want to emphasize, it cannot be given unless the patient consents, or the healthcare practitioner can justify the disclosure. So it's always prudent to ask your patient, can we disclose information to a third party? Would you like your husband, wife to know the details? That's fine if you have a patient that's awake and talking. It's not always so easy when you don't have a patient that can give you that consent. So the specific circumstances where you can disclose to third parties, there are a list. Obviously, if you have a court order, you so by order of the court to disclose things. If it's a notifiable disease, then you are legally obliged to notify and disclose that. And if you think, for example, with children or any situation where you think there's abuse. So if you need to protect the patient, then you can. So just remember, the patient's best interest is paramount. So you need to consider the patient's best interest, and you need to be able to justify why you disclose. And then, very important, you always need to document if the consent is given and the rationale for disclosure. Okay, the reason I'm talking about confidentiality and disclosure is because we do it all the time. We're in ICU, we have a patient on a ventilator, and our relatives are all clamoring to know what's wrong with the patient and what's happening. Okay, that's an interesting situation. I can't give you an answer to what the right thing to do is. Morally, you know that you have a relative who's really concerned. And if you are in that situation, if you were the relative, you would want to know because you are concerned. So you need to justify. So you can see that it's not the easiest thing. So there are times where you might break confidentiality by counseling family members, but you need to just have a rationale. So you need to actually be able to justify why you're doing it, and just make sure that it's in the patient's best interest to do what you're doing. Okay, if you have to make a decision, and to disclose things to a third party, to a relative, for example, then once your patient wakes up, you must tell the patient that you have disclosed it. Okay, so that's the legal part of disclosure. Okay, another thing that I just want to, I think is another area where it's not done correctly, is consent. Informed consent. That is part of autonomy, and it's a patient's right to give consent and to refuse treatment if necessary. For informed consent, it's always required for any medical intervention or procedure. Now, this informed consent doesn't necessarily mean it has to be written, although a written document is always better for you, and any documentation obviously is better. So if you can get informed consent and written, that's fine. But there's also implied consent. The patient comes to you asking for help, and they come and you do a consult with them. That's implied consent. You don't necessarily need to have that written, because they're coming to you and asking for help. Okay, if you have a procedure, the person doing the procedure should ideally be getting the consent. Again, I've been in a situation where my husband was admitted to hospital for a procedure and was given a form to sign. Said, sign this as this is your consent, without having seen an anaesthetist or the person who's going to do the procedure. Being a medical practitioner, I told him not to sign until he's being spoken to by the person. And unfortunately, this happens. The patients are given this form, here, sign, this is consent. Consent needs to have enough information. So in order for a patient to give consent, to make a decision, they need to have all the facts. But they must, as I'll mention later on in the talk, must make sure that the facts are easy for the patient to understand. So consent is something that is not well done. And it's something that you could be taken to court about. So please make sure you do get your consent done properly. Okay, and remember, patients always have the right to refuse treatment, and you can't change their minds. If you've given them enough information, if they refuse and they understand the consequences of refusing, then it is their right to refuse. Okay, let's get back to the nitty-gritty. I've said that we don't communicate very well with our patients and surrogates. So let's see, how can we make things better? And I'm going to go through some of these. Some of these I've already covered, so let's see what we can do. Right, everyone, now close your eyes. And I'm going to now open your eyes. Okay, sorry for the quality of the video, but I think it actually helps. Can you imagine yourself waking up to that? It happens to a lot of our patients. Just think, for example, the trauma patients. They're involved in a trauma, they go to theatre, and they end up in ICU. You wake up to this noise, this strange person next to you in a strange environment, which is very alien. Think about it. How would you feel? I'm pretty sure you'd all feel very anxious and you'd panic. Right. So put yourself in this position. How would you feel? You would definitely be scared, anxious, and panicked. And that's exactly what your patients are feeling. And that's one of the main things that the people I've spoken to, who are patients, including my husband and some of my friends and other people that I've spoken to, is that patients feel like they've been dehumanized. They're not human beings anymore. Remember, healthcare staff are strangers. You wake up and see all these strangers around you. You're in a hospital bed, and all there are, there's nurses and doctors and physios. Everyone's a stranger. They're doing very strange things in a strange, alien, frightening environment. Okay. Remember, this is for patients, this is a strange environment. We come to a hospital on a daily basis. We walk into ICU, we walk into theatres, we walk into the wards. For us, it's actually not alien. This is where we work. We're used to it. But put yourself in a position of someone who's never gone in there. They don't know what this place is. It's strange, it's frightening. So remember, your patients are scared. There's a loss of personal identity. And this is one of the key things that keeps coming up when you speak to patients. They feel like they're just a piece of, they're not a human being anymore. They're just there as a patient. I mean, how many times do you refer to a patient as a diagnosis? That patient in bed 2 with cancer, that patient in bed 3 with pneumonia. Okay. How often do you do that? So they've lost their personal identity by you doing that. So try and remember your patients' names. Not always so easy, I know that. But it's something that I try and do. And I try and encourage doctors working in the ICU to do it. Mention the patients by name. Look at the name. See who you're talking to. And patients don't get spoken to. There's no communication. So, yeah, the doctors do their ward rounds. They look at the charts at the foot of the bed, speak to the sister, speak to the other doctors that are there, or the students if you happen to be there. They don't tell them what's going on. So nobody speaks to you. There's no family support or presence. They're all alone. Okay? This was particularly bad during COVID when we didn't have visiting time. Patients went into hospital. They ended up in a hospital bed, scared, and there's no family or anyone there that actually knows who you are. And then there's the loss of your dignity and privacy. So patients are scared and anxious, and there's a loss of control. So patients have no say about what happens to them in hospital. So how can we do something about that? So when you see a patient, you walk in, you walk around, identify yourself. Introduce yourself, say who you are, okay, and talk to your patients and the families and explain what you're going to do. Don't just come in and say, okay, roll up your sleeve, I'm going to. So tell them you want to take blood, you want to do a procedure, you need to put up a line. At all times, acknowledge your patient as an individual and show respect to the patient. Right, ask yourself, how would you want to be cared for? This is a common situation in a casualty. A trauma patient or a surgical patient is lying there exposed with blood. How do you, if you were lying there, how would you want to be treated? Patients need to know that they are still human beings. They need to know that you see them as a human. Okay, privacy and confidentiality is also very important. They feel that they've lost their sense of privacy. Confidentiality we've touched on. We tend to forget the human side of patients, and I'm going to repeat this time and time again, and the privacy and dignity of patients. Quite often, you come in and patients are exposed. Okay, remember they're wearing hospital gowns, which are not exactly the most, not the most comfortable things. And ward rounds. People come round, talk to you, prod you, poke you, take blood. Okay. So remember that. Remember to draw the curtain around your patient. Remember that there are other patients in the ward and they can hear what you're saying. So try and be cognizant of that. Okay. And if you are doing a teaching round, for example, tell the family, tell the patient, if they're awake, that you're going to be teaching. Okay, what you say may not necessarily be about them, But just make sure that you don't say anything that will frighten the patient and upset the patient. Then we get to how much do you tell families. Now, what we tend to do in ICU and at Barra is we actually get the families to nominate one person that we talk to. We can't talk to every single family member. Most often, most commonly, it's the surrogate. So it's the spouse or the brother or whoever is the surrogate, so parents from the child. And we have one spokesperson. So we have the surrogate, and you speak to them. Because what tends to happen if you speak to more than one family member, the lines get a bit crossed. So you try and speak to your surrogate and let them know. The most common question you get asked by family members is, but they're going to be okay, aren't they? Don't give false hope, but also don't let them lose hope. Hope is one of the most powerful things that you can give someone. So you must just make sure that you are realistic, but hopeful. So don't scare people, but also be realistic. Right. How many of you can read this? Any mathematicians in this group? I didn't think there would be many of you. Okay. But we do this to our poor patients. We use medical jargon. Okay. So we sometimes hide behind the medical jargon. Have a look at that. Cardiovascular risks associated with hypertension, obesity, physical activity levels. The poor person is saying, huh? And then what she really means is heart health is affected by blood pressure, being overweight, and lack of exercise. You see what I'm getting at there? Is make it easy for patients to understand. Again, coming back to my own family, I'm the only medical person in my family. So I've been taught by my lawyer husband to talk in layman's terms. He often tells me that I mustn't use medical jargon, and please. So I've had a bit of practice. But yes, just remember that these poor patients have no idea what you're talking about. So please refrain from medical jargon. It's often actually easier to talk to relatives who are medically trained. But yeah, so just remember that. Please don't use medical jargon on your poor patient who has no idea. So use appropriate language. Remember, medical terms are meant for medical practitioners, not patients. And medical jargon can just cause confusion. And then if you have a confused patient, it just leads to fear and mistrust. Remember, so keep it simple. When you talk to patients, make it nice and simple. And you can make it simple. Next, as I mentioned before, one of the things that dehumanizes patients is the lack of family members and the lack of people that you know. So visiting policies are very important. And there are no standard visiting policies. These are taken from all over, and you can see they're all totally different. This became a major problem during COVID, where people weren't allowed to visit. How we tackled that at Barra was that we did video conferencing. We managed to get someone to sponsor Wi-Fi in our COVID wards, and we got a tablet, and we did a video conferencing so that the patients could still speak to their relatives. But this is important. Family members are very important for patients. Also, a lot of visiting times are totally impractical. Okay, if you are a working person and you need to go and visit your relative, it's really impossible to visit during the day when they want you to visit. So I think you need to look at your visiting policies Barra ICU has a very open visiting policy. Well, now that our visiting hours are back to normal, we also had restrictions during COVID. We try and encourage family members to come. It is very important. This is just an article I found in a paper. This was actually in the UK, where they decided to cut visiting hours. And patients were furious because now they didn't see their relative. Again, from personal experience, my husband said that he felt the calmest when I was there, and he was very anxious when I wasn't there. And that's the same for a lot of people. They're relaxed when they're there. Well, that depends. I suppose if you don't want that patient there, that person there, then they won't be relaxed. But yes, generally patients want to have their relatives there. So what are the effects of limited visitation? And we saw that during COVID. Again, the patient is dehumanized. There's a loss of control. They're stressed and they're anxious. They don't have that family support that they need when they're really ill. The family, it's just as bad for the families to wait outside, waiting for information. There's stress. They don't know what's going on. They're scared for their relative as well. Again, there's loss of control. And just be aware of the disruption of family life. And again, that comes from when you have limited visiting times and specific visiting hours. Often it's during the time when you have to go and fetch your child from school, or you have to drop off the child, you have to supervise homework. So there's a total disruption of family life when a family member is in hospital. So visiting policies, open visitation, a lot of research has been done on it, and it has been shown that patient-centered family visitation works very well. So restrictions are driven by patients. The patients don't want to see their visitors anymore, then they're asked to leave. If the patient wants a visitor and it helps them when their recuperation, then they should be allowed in. They found in studies that open visitation causes less anxiety for the patient. The patient feels much more comfortable, secure, and they're much more motivated. There's less traumatic stress. It does shorten ICU stays. You can help the staff. The mother can help feed the baby or change the baby. You use the mother to help with your children in ICU or in the wards. And there's much higher family and patient satisfaction with open visitation. Okay, so who can visit? Okay, a lot of them restrict visitation, which is fine, where you say 2 visitors per patient. Up to a point, yes. So it also depends on your patient. I think 2 visitors at a time is probably prudent. We do relax that when we have a patient who is terminal. When the patient is dying, we do allow more visitors. So that, especially if they want to come and pray and be there with them. So at Barra RC, we do let more visitors come in that situation. No children. Now that's an interesting one. Sometimes you have to let children in. Remember, children, don't underestimate children. I had a colleague of mine who, to this day, was still very upset that they were not allowed to go and visit their dying parent. And it caused an enormous amount of stress. I do allow children to come in to see patients in ICU, but under controlled circumstances. Every single child that comes in is prepped beforehand, and it's explained to them what they're going to see. The other parent or caregiver at this stage has to go in with the child And as soon as a child is shown to be stressed, we do take them out. So it's very tightly monitored. One of the most poignant and sad things I ever saw was a child we let in to say goodbye to his mother. It actually had everyone in tears because he was about 10 years old. He came in and he did say goodbye. And his dad was with him. And it was heartbreaking for everyone, but it was very, very important for that child, for closure. So just think about it. Obviously, it has to be controlled, but think about who you let in. Right. The picture, these pictures are with consent, by the way. The picture with the gentleman in the orange. This is the first time this lady is seeing her newborn baby. Okay, that's her husband. She'd been in ICU for a few number of days. She hadn't seen her child. So we got Dad to bring the baby in. This was an incredible motivation for her. She was very depressed beforehand. She hadn't said hello to her baby. And when we brought the child in with Dad, it motivated her to get better. And then we've done it a couple of times. It's an incredible motivator. They see their baby, they bond for the first time. So it was something that we all enjoy when that happens. It's really such a nice thing to do. The one with mommy, this child was crying nonstop. We eventually got mom in and we let mom stay with the child. And you can see here she's helping feed the child. He was refusing to do anything until mom came. So you can utilize your parents. Get them to feed the child, comfort the child. There's nothing better than a mother to comfort a child. So please just try and be aware of that. I know a lot of intensive care units let mothers in and let them stay there. And that's very important for the child and the parent. Right, here's something nice and controversial. Animals and animal therapy. Okay, it's not necessarily for ICU, but in general. Again, animal therapy has been shown to be beneficial. I have had patients who have asked to see their dog or their cat. It's a bit of a technical problem. It takes a lot of work to do it. You have to get a lot of permission, but it's incredibly beneficial. As you can see, this child is on a ventilator and he's got his dog. And it's a comfort to him. So it is something that we need to think more about and do more, and with animal therapy. So think about it. I'm not saying you have to do it. Then your environment. This is at Barra in our ICU. The first one is the waterfall is on the stairs coming up to the ICU. It's one of my favorite pictures and it's one of the most relaxing pictures. And then the one in the waiting room. We have a beautiful picture. So we try and make it more relaxing for the family members who are waiting to hear about their loved ones, who are stressed about their loved ones. Remember to create an environment that is soothing to the patient. Information is important. Information brochures, signboards. So let the patients know. So when a family member gets admitted into an ICU, into a ward, let them know when visiting times are. What are the rules? What can they bring to help their family members? Do they need to bring toiletries? And all sorts of things. This is a strange environment for people. So let them know. Give them an information brochure. Give them phone numbers for the ward so they can be contacted and find out how their relative is. So remember, patients are human beings with feelings and emotions. You could be in that position. You could be lying in that bed with all those medical staff around. You want to be treated like a human being. So remember that they have feelings. Respect the human dignity. Make sure you keep the conversation simple and understandable. Remember to be empathic and compassionate. These patients are scared. They're in pain. They're hurting. So be compassionate and be flexible. And this is specifically for things like visiting and who can visit. And remember to treat all patients as human beings. I'm going to finish with this video, and I think it sums it up very nicely.
I woke up in intensive care. My eyes were swollen shut. I couldn't see. My jaw was wired closed, and there was a hole in my throat, so I couldn't eat, I couldn't speak, I couldn't drink. And there was a machine forcing air through the hole in my throat, so I couldn't even breathe for myself. But I could hear everything. And I searched through all the noises of a busy intensive care unit for any sign about what was happening or likely to happen to me. And then a machine would beep loudly. I couldn't see, and I didn't know what it was. And I thought that maybe I was going to die. But somebody would come and they would reset the alarm and move away silently. And the doctors would come around the bed and they would discuss my case in great detail with each other in a language that I didn't understand. And then they too would just quietly go away. And at night, nurses would come and they would attend to the IV lines that fed and hydrated and medicated me, and they would take notes, I suppose, and read things. And they attended to my physical needs with skill deficiency, but they never saw, they never acknowledged my emotional wounds, except for one special nurse. Every time he came in to look after me, he would lean close to my face and put his hand on my shoulder. And I could see through the slits in my eyes the outline of him, and he would call me by name. And then he would tell me what he was going to be doing that day. And then he did something that not one other person did for the 3 weeks that I was on life support. He talked to me like a human being. He would talk about everyday things as he went about cleaning my wounds, cleaning my body, washing me, changing my clothes, checking my IV lines. He would talk about things like what kind of a day it was outside, or who would come to visit me while I was asleep. He talked about common everyday things. And it didn't take him a moment longer than it might have taken otherwise. People are so afraid that if you make a human connection with the patient, that it's going to take too much time. It took him no extra time. And yet, 20 years later, it was 20 years ago that I had a multi-trauma accident that nearly killed me and kept me in hospitals for 17 years. But I remember him, and every time I speak, I tell the story of this nurse, this wonderful man, and how much his touch that didn't hurt, that wasn't efficient, how much that meant to me, how much telling me what the weather was like outside, or telling me a little anecdote about something that was on the news, anything like that reminded me that I was more than a broken body. And I will never forget him. And it's 20 years. And I still feel the gratitude of that more deeply than I can express to you.
So yes, hopefully the patient has given you the same message. So just remember, talk to your patients. Remember they're human beings. It's something we should all do. So thank you very much.
Oh, thank you very much, Dr. Brown. That last video clip is so touching. I think it brings tears to the eyes. As you say that we don't talk enough to our patients, and what a wonderful nurse that man is. Sometimes when you speak about the nurse, you default image, it's a woman, and she speaks about a man. So it doesn't matter what gender you are. If you're committed to your profession and good at it, you can make a difference. And thank you very much for sharing that video, and also for a wonderful presentation. I will open up this discussion for more questions and interactions. If there's anyone who's got a question to ask, please do ask a question, and Dr. Brown will willingly answer those questions.
Well, I'll try. I'd always
No, we work as a team. Yeah, we work as a team. Yeah, I'll take this one from Dr. Mtembu, Mongani Mtembu. I'll go through the others. He says, thank you so much for a thoughtful presentation. One question, when does one draw the line on the information to be communicated, especially in high care in ICU? When you...
Sorry, you broke up.
No, it says when in ICU setting, ICU high care, when does one draw the line on the type of information to be communicated, either to the surrogate, as opposed to the surrogate mainly, or to the concerned family member?
Okay, yeah. I think you have to individualize. You have to be in high care. Hopefully your patients are awake. So in high care, you can actually speak to your patients and get their consent. So you can actually ask your patient, do you want me to speak to your relative? How much do you want me to say? Or you can get the patient to bring the family member in and talk in his presence. So I think you need to individualize, definitely individualize it. But yes, if you have the opportunity to ask your patient for consent to tell the family member, then you should. And it's maybe something that you should also think about. I mean, a lot of the high care patients of that post-trauma, post-surgical patients, and maybe it's something that you can discuss with your patient beforehand. And how much would you like your relative to know? So how much you draw the line, I think you have to individualize. I think it depends very much on what's wrong with the patient, how serious it is, and how much the patient is willing for you to tell them.
Yeah.
I don't know if I've actually answered that, but I think you have to individualize. I can't give you that exact.
It's a tough one. I know that you were saying you wish that all of us could be patients or family members of patients. I've been in a situation like that.
I don't really wish it on anyone, but I think it's a very useful thing.
Yeah, in a very difficult situation. I think I'm raising this now when you speak about surrogate. Because Dr. Bohaba wants to know, maybe if you go back and explain what a surrogate is. And I remember earlier this year, I lost a cousin brother, and he was in ICU, and also the family wanted to know, I mean, what's the prognosis? And in my position, speaking to the doctors, they would then, I think I was somehow nominated in a way as a surrogate to explain to the family what was going on. And it's a bit difficult to let the doctors explain to you in detail, you can understand medical jargon and explain that to the family members to know what was going on. Yeah, so he wants to know what's a surrogate. Tied to that, moving away from being a family member, being administrators or hospital CEOs, etc. From time to time, you get calls from people who want to know about patients in the hospital, and they are not family members. Sometimes they're close, but they're not nominated. But they want to know, and they ask you as a hospital CEO or hospital manager, or to say, "Can you tell me about Dr. Brown? What's the progress? What do you do? Or how do you advise people like me and others who are like me was sitting in this audience?" Maybe starting with the first one. Yeah.
Okay. Well, first of all, a surrogate, as I mentioned before, preferably the patient should nominate their own surrogate. But if it hasn't happened, which is most common case, it's usually the next of kin. So as I said before, it's the spouse, the partner, the parent, grandparent, siblings. So they become the surrogate. And again, as I said, the surrogate should be the one that makes decisions depending on what the patient wants. How much you tell them? Yeah. The surrogates, I think, we tend to tell them everything. Well, everything. We try and be as honest and open as possible, and truthful, realistic, but without taking away hope. I think, especially in a case where you are expecting the patient to not make it, I think you have to be as honest as possible. And I think it's up to you to prepare the family as well. You don't just have one patient there. If you have a patient who is dying, you actually have more than one patient. You have a family as well. That's part of your job. And you have to prepare that family. You can't just tell them that the patient is going to be okay, and the next thing they hear is the patient's died. That's not fair on the family, and it's certainly going to make them very angry, because they're going to say, but you said they're going to be okay. So you do need to prepare them. It's something that something that comes with experience. It's not something that people can just do. You have to give them the facts. You have to understand that they may not take in everything at that time, and they will have questions, and they'll come back to you and they'll say they didn't hear that, because sometimes patients and families hear what they want to hear.
Yeah.
So you've got to be aware of that as well, and just be sympathetic and empathetic, and understand that patients and family members actually can sometimes not remember what you've told them, not understand what you've told them, come back to say, you haven't told me. And a lot of it may be denial. And you've got to remember that they're also going through all the phases. So there's denial, anger. And some patients, family members get angry with you. So it's all part of the grieving process. And you've got to remember that when counseling family members. So yes, I think in a case where where you don't expect the patient to make it, or they're very serious deal, I think you do need to be honest with the family so they can prepare themselves. With regards to non-family members, you actually can't tell them unless they've been nominated by the patient. So you can't, without the patient consent, you actually can't really tell them. So what we basically, is patient stable, or typical jargon that we say. But then we advise them to speak to the family member that we've nominated. We say, please speak to the spouse. We've already explained everything to them.
Yeah.
Coming back to your comment about medical practitioners, it is easier to speak to someone who's got medical training. Absolutely, that's definite. And if the family members have asked, the surrogate has asked for that, for example, their GP to come and speak to us, then we will give them some explanation, because it is easier to speak to a medical practitioner, and then it's someone, for example, the GP, that would know the family, and they trust that family member. But an arbitrary person that just asks, you actually can't give us information.
Yeah. Thank you. Thanks for that. This question is about Dr. Matt wants to know, what's your feeling about high care ICU patients, whether in public or private, with cell phones in hand, that she had a patient with COVID pneumonia started deteriorating after getting a call that her husband had passed and had a heart attack. So they get sad news because they've got access to a phone, and that gives them, in contact with what's happening in the outside world.
You can't change that. Yeah, that's always a difficult one. Do you tell patients bad news while they're sick? If they find out, you're going to have to deal with it. You can't stop other. I mean, also other family members may tell them as well. It's not just
Yeah.
at home. You can't stop it happening. They're going to find out anyway. They get out of. It's similar to a situation where family members tell you not to tell the patient what's wrong with them. But
Sure.
you can't actually do that. They will find out eventually. And a lot of patients will get very upset if you withhold information, especially something as important as that. I think you have to be tactful, you have to be sensitive, compassionate and empathic when you do it. And I think you have to, again, you have to look at each patient individually. How do you think they're going to take it? Yeah, sometimes it may be better not to say anything, but again, as I said, you have to take it as individual. They will find out eventually. So you can't keep it from forever.
So
you need to be empathic as possible.
Thank you. So it's better to tell them.
Sorry.
Also, you say it's better to not withhold information, but to share information as much as possible when it's possible.
Yeah.
Okay.
But
now,
do it gently and compassionately. Yeah.
Yeah, always. Yeah. This one from Dr. Machache, I like this one. Patient refuses hospital treatment and they sign an RFT and they want to go home. But they want to go home with treatment. Do you give them treatment?
That's an interesting one. Probably. It depends on what it is, though. Look, as I said, I work in an ICU, so it's actually not something that we come across too often, that our patients want to leave ICU. And most of our patients are not capable of leaving ICU. So it's not something I come across very often.
Maybe make it a bit much easier, maybe to in context to where I understand it, situation that I come across. A patient is on oxygen supplement, and they want to sign an RHT, and they don't have access to oxygen supplementation if they leave the hospital. Because in the hospital, they can get it. What do? Do you organize for them to get it? Like Dr. Machache says, it's a form of treatment to get home oxygen if they leave the hospital, but you record that they should stay in the hospital, but they insist on leaving the hospital.
Okay, as I said before, patients have a right to refuse treatment, and you can't stop them. As long as they are aware of the consequences and you've explained the consequences of them refusing treatment, and they know, you cannot stop them leaving. So you have to let them go. But what you can do, yes, if you can try and organize supplemental oxygen to take home, then I think you should. And yes, you can do that. But patients must be very aware of the consequences. And I think that's the important part. They can refuse, but they must, and it must be documented. You must document that you have told them the consequences thereof. So yes, you have to let them go. You can't keep them against their will. And I think if it's treatment that you can organize for them to have at home, I see no reason why you can't organize it. So I can't organize a ventilator at home, but yes, supplemental oxygen can be organized.
Okay.
It was a bit difficult during COVID, but if possible, yes, you can send them home on treatment.
Okay.
Within reason. I mean, I don't think you can. No, I'm just thinking. I mean, you can't. As I said, I can't send someone home on a ventilator. IV might be possible if you've got a reasonable nursing or community nursing, if they're prepared to do it.
Yeah.
Or someone in the family who's medically trained, then you can do it as well. But yes, you can't stop them from going home.
Okay. The RHT, how is the doctor affected by a refusal of hospital treatment by a patient? I think the question is, will the doctor bear the consequences if the patient goes home and then something happens to the patient?
No, they won't. As long as I said, you've explained everything and it's all documented. and this patient has signed that they understand the consequences and they're refusing treatment. The doctor won't be held liable, but it has to be documented. And, yeah. So no, they won't be, as long as they've told the patient.
Yeah. So Dr. Soga says, thank you very much. Quite amazing. Thanks for that awakening human being within us. Said how much we can deeply hurt those who dedicate so mischief of our time to care for. Thanks, Dr. Brown.
Thank you.
And the question from Dr. Peter Williams-Ashman. What medications are you using to assist in calming and management of agitation?
Sure, okay. Okay, we're in state, remember, so we are in
you're
state.
Becoming much calmer that time when I was asking this question.
What do we use? Dormicum.
Yeah.
Dormicum, morphine, we use Presidex every now and then, but yeah, we're a bit limited with what we've got in state. Yeah, so yeah, the benzos. Yeah, that's mainly what we use.
For a moment, I thought you've taken that medication yourself.
No. As I said, when it's a topic like this that I feel passionate about, I don't have a problem talking.
Yeah, I'm glad we've got quite a number of physicians also asking questions here. Dr. Wayne Adu, who's a physician, how does one resolve a situation where the family gives a list of visitors allowed, often leaving out girlfriends, whereas the patient is keen on seeing the unofficial partner, the girlfriend? And nurses are often at the receiving end of the anger of the family. Family feuds, family dynamics.
The patient is your patient, and it's the patient's right. So that's where you have autonomy. Part of your ethical principles. It's the patient's right to decide who comes in, not the family. The family are not your patient, so the patient needs to decide who he wants to see, not the family, unfortunately. Yeah, we've had that situation where we've had two people come in as both claiming to be the wives of the patient. So it's very interesting. Yes, so then you just have to find out from the patient. Obviously, it's a bit difficult when our patients can't tell you, but yes, and we've had stand-up fights. Two wives come in. But
Two
yes,
wives.
it's interesting. Two wives come in, and both of them were chased out and told to leave until they sort out their differences. Yeah. No, but it's basically it's a patient's decision, not the family's.
Yeah.
And it has to be made very clear. Yeah. So it has to be made very clear to the family that the patient is your patient, not them.
Yeah. I mean, like your topic says, we must talk to the patients or surrogates. Yeah. Now, this one is very interesting from Dr. Mulau. Says, now we've got two professionals. I don't know if they're treating the same patient, but they've got a different...
Sorry, right? So you broke up there.
Yeah, I hope maybe my internet is unstable, perhaps. So two healthcare providers, two professionals treating one patient, they seem to have a different opinion about what's wrong with the patient. So then how does one explain to the patient or the family member if asked about a treatment being offered by a colleague? So it looks like the colleagues don't seem to be seeing the same situation. And how does one deal with the matter without criticizing the other colleague?
Oh, okay. Thanks. Okay. You probably... Well, that's an interesting... I think what you actually need to do is get together beforehand and discuss what you're going to tell the patient, because you can't confuse the poor patient. You can't have one person telling the patient one thing and another saying something else. So I really think the two clinicians need to get together and decide what they're actually going to tell the patient without confusing them. I know it's not as easily done and said, but I think you can't criticize a colleague. You can't contradict the colleague. So it's much easier if you just get together beforehand, decide what you're going to tell the patient, and then if you can sit together with the patient, so the two physicians sort of seeing the patient together, jointly counsel, and that we found actually works very nicely, where we get the physician or the the surgeon to come in and counsel at the same time.
Yeah.
So that at least we know what the other person is saying and try not to contradict each other. But I think try and get that sorted out before you speak to the patients. It doesn't put us in a great light if you're contradicting each other.
Yeah, definitely. Yeah. Sure. I don't see any further questions, and I'm not sure if anyone has got a question to last minute who wants to unmute themselves and ask a question. But if not, so at least we've got to spend about 20 minutes or 10 minutes. And I'm going to ask Dr. John Bohopa, who's our Group Occupational Health Manager at Clinics Health Group, just to do the closing remarks.
Thank you very much.
Yeah, it's been wonderful. I enjoyed the chat.
Thanks. Okay.
I'm going to watch the video clip once more.
Okay, thanks. Okay. Bye-bye.
Sure.
Dr. Bila, good evening, colleagues. I hope everyone is well. A thoughtful and provoking discussion indeed. And I think I can resonate. I think I heard one Dr. Lindile saying, thanks for awakening, the human being within us. And I think it is obviously presentation like this, that once again remind us of our roles, the roles that we play as clinicians in relaying information to our patients, especially at very critical times, like settings like in the ICU, when patients are obviously at dire need of communication and explanation of the symptoms that they are going through. I particularly liked the inquiry that was made by Dr. Adu about girlfriends in the ICU setting. It is equally very, very interesting as to how do you then handle that situation as a clinician. But Dr. Brown, thank you very much for your interesting presentation. And once again, as a reminder to all the colleagues that have tuned in, we thank you. And we ask you once more to tune in next week for yet another interesting, presentation. And as Dr. Bila has said in his opening remarks, if there are colleagues, who wish, to come and present on this platform, who have interesting, topics, in whatever, medical field that is, of interest, if I may put it that way. We recently had people and surgeons presenting on robotic surgery. We've had, presentations on very interesting, groundbreaking, medical inventions. So we ask if there are colleagues out there who want to present on this platform, you are welcome to contact, Dr. Bila with the Clinics Health Group, so that we can also hear you out. Once again, colleagues, thank you very much for the beautiful presentation from Dr. Brown. And on behalf of Clinics Health Group, I would like to close this presentation. Thank you very much, colleagues. Good night.